In terms of strength, what are we starting to add? This is a pretty fun time for the patients, right? Because we're introducing some more challenging strength and they're starting to feel like they can actually exercise again, which is pretty nice. So, week 6, after we finished our kind of transition week, when we did our weight bearing, right, and we started to do gait training, I start to introduce single legged strength. Okay. And my favorite exercises for single legged strength are going to be single legged squats, single legged deadlifts, right? Some sort of step up, and usually some sort of split squat. Okay. And here's the thing: the split squat or the lunge, the forward lunge and the reverse lunge, have all been shown to have very little stress on the ACL graft. Okay. However, they're looking at the front side leg. And in the front side leg, you have the hamstring and the quad working together, which is going to reduce stress via co-contraction on the ACL graft. But on the back side leg, the trail leg, the quad's very active and the hamstring is not. Okay. So if you think about a split squat, the trail side leg is very similar to an open chain knee extension and probably puts more stress on the ACL graft. Okay. So, one of the things that I'll do oftentimes is I introduce single legged squats, single legged deadlifts, and step ups because I know it's very low stress on the graft. And oftentimes I'll wait until week 7 to introduce a split squat because I know that we're putting a little bit more stress on that backside leg. And if you want to be really cautious, you could hold off on that split squat until week 12, right? I don't know that we need to do that, but just keep in mind that this is something that's not talked about frequently. But the backside leg of a split squat or lunge is stressed very similar for the ACL as an open chain knee extension. Okay. When we introduce single legged exercises, we start with partial ranges and oftentimes assisted. So we've got a picture of my patient here, and she's doing a partial range step up, and she's utilizing a very short box, as you'll see, and she's using a TRX for assistance. So I'd much rather start with an easier variation with good form, okay, and not aggravate the knee. And over the course of time, we can always make this more challenging. We're also looking for compensation. Okay, so the same strategy applies. If you have access to a force plate, great. You can use that to see if they're transitioning weight onto this leg well. We can use a mirror, right? We can also use video biofeedback. So I'll often take a video of the patient and just show them, like, hey, your knee is not translating anteriorly. You're sending all your weight back to your hip. Let's try to drive that knee forward just a little bit because when you do a step up with the other side leg, the knee is coming forward a lot, but not on that surgical side. Okay. I'll also use a bench for biofeedback. So if someone is doing a step up or a split squat, I'll actually put a bench in front of their knee and I'll ask them to reach the knee toward the bench on the surgical side because folks that just had knee surgery, they don't like to load up that knee. They don't like to bring the knee over the toe or beyond the toe. I will actually give them a bench to reach toward to give that cue so that they actually load up the knee a bit more, load up that quad. So week 6 to 10, we're still continuing direct knee isolation strength work, okay? And this is for the quads, but also the hamstrings. The hamstrings are going to be weak. And if you're working with someone that had a hamstring graft, keep that in mind. That's also going to be weak as well. Do keep in mind, this was not a hamstring graft, okay? So when we load up the hamstring after a hamstring graft, it's not the same as when we have a cadaver graft, okay? In terms of the exercise we're using for the quads, we increase the challenge of the exercise. So most of the exercise we started with were table exercises, okay? Now we're transitioning into weight bearing. And one of my favorite exercises for weight bearing quads are heel taps. I'll do a heel tap with a internal knee extension. So I add the two together. I like to try partial sissy squats with a internal knee extension, which is basically a squat where you really push the knees forward. I also like heels elevated goblet squats for the same reason. If you elevate the heel, it's going to force that knee forward, which is going to make the quad work a bit more. You do have to be cautious with these. They can create quite a bit of knee irritation. I do find that in folks after ACL reconstruction, they end up with other pain problems. So it's not just that you're irritating, like, I don't know, the prior ACL, or you're irritating that meniscus or whatever was injured within the initial injury. You might be creating some patellofemoral pain just because you have a weak quad and you're deconditioned. So you have to be cautious with how much stress you throw at that knee and not just the graft, okay? We're also continuing to work the accessory muscles. So we're working the core, working the hips, working the calves, and we're doing our blood flow restriction training 1 to 2 times a week, okay? So here's the thing. BFR is phenomenal for the early stages of rehabilitation. And the reason being is because early on with rehab, we can't load up that area with heavy weights, okay? And we can get a similar improvement in strength and hypertrophy by adding BFR without the load, okay? As someone progresses and they're able to handle more load and more power and more skill-specific work, we actually start to phase out the BFR, okay? It's still a nice ancillary, and I'll often keep it in the mix, but do keep in mind that BFR is more for the beginning stages of rehab. It's not really used for the advanced stages, although I think you can make a case for it, okay? The other piece is that we're working on balance and neuromuscular control. A lot of single-legged balance on unstable surfaces with perturbations, kind of like we did prior to surgery. Okay. Also, keep in mind is that your ACL is important for proprioception of the knee. Okay. And you lost your ACL. And now you have a new ACL. So you have to restore that proprioception again. So the balance is actually quite important. Okay. And quite important from a perspective of reducing re-injury rate as well. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain Free Mini Course. And we go over 3 lessons going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay. So a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a Fitness Pain Free Mini Course. Definitely check this out.